Welcome to Sciencera. In this video, we're going to discuss growth adaptation, cellular injury and cell death from Pathology at Glance, unit number 1. Let's begin. Growth adaptation. 6 things we're going to look in this section is basic principles of growth and adaptation, hyperplasia and hypertrophy, atrophy, metaplasia, dysplasia and aplasia and hypoplasia. Let's begin with basic principles. An organ is in homeostasis within physiological stress placed on it. An increase, decrease or change in stress on the organ can result in growth adaptation. Hyperplasia and hypertrophy. An increase in stress lead to an increase in organ size. Hypertrophy involves gene activation, protein synthesis and production of organelles. Hyperplasia involves the production of new cells from stem cells. Hyperplasia and hypertrophy generally occurs together, for example, uterus during pregnancy. Pathological hyperplasia, for example, endometrial hyperplasia can progress to dysplasia and eventually cancer. An increase in stress leads to an increase in organ size. It can occur via an increase in size, which is hypertrophy, or number of cells, which is hyperplasia. We said that hyperplasia and hypertrophy generally occurs together. For example, in uterus during pregnancy. Number 1, permanent tissue. Cardiac muscles, skeletal muscles and nerve muscles, however, cannot make new cells and can undergo hypertrophy only. Cardiac myocytes are example of this, which undergoes hypertrophy and not hyperplasia in response to systemic hypertension. Hyperplasia is the number of cells, increase in the number of cells, and hypertrophy is the increase in the size of the cell. Next is pathological hyperplasia, which can progress to dysplasia and eventually cancer. A notable exception is benign prostatic hyperplasia, which is also known as BPH, which does not increase the risk of prostate cancer. Atrophy. A decrease in stress, for example, decreased hormonal stimulation, disuse or decreased nutrient blood supply leads to an decrease in organ size. Decrease in organ size is atrophy. Decrease in cell numbers occur via apoptosis. Decrease in cell size occur via ubiquitin, proteasome degradation of cytoskeleton and autophagy of cellular components. Decrease in stress, we said, leads to decrease in organ size. It can occur via a decrease in size and number of cells. Decrease in cell size occur via ubiquitin proteasome degradation of cytoskeleton and autophagy of cellular components. Number 1, in ubiquitin proteasome degradation, intermediate filament of cytoskeletons are tagged with ubiquitin and destroyed by proteasomes. In autophagy, a cell of cellular component involves generation of autophagic vacuoles. These vacuoles fuse with lysosome whose hydrolytic enzymes break down cellular components. So this is your atrophy. Next is metaplasia. Number 1, a change in stress on an organ leads to a change in cell type. Change in cell type is known as metaplasia. Barrett esophagus is an classical example of metaplasia. Number 1. Most commonly involves change of one type of surface epithelium, squamous columnar or urothelial, to another. Metaplastic cells are better able to handle the new stress because they lead to the change in cell type. Barrett esophagus, a classical example. Esophagus is normally lined by non-keratinizing squamous epithelium suited to handle friction of food bolus. Acid reflux from stomach cause metaplasia to non-ciliated mucin-producing columnar cells, better able to handle the stress of acid. It can occur via reprogramming of stem cells which then produce the new cell type. Under persistent stress, metaplasia can progress to diplasia and eventually lead to cancer. Vitamin A deficiency can also result in metaplasia. Mesenchymal or connective tissue can also undergo metaplasia in body. It is reversible in theory with removal of driving stressor. For example, treatment of gastroesophageal reflux may reverse Barrett esophagus. Under persistent stress, metaplasia can progress to dysplasia. For example, Barrett esophagus may progress to adenocarcinoma of esophagus. A notable exception is apocrine metaplasis of breast, which carries no increased risk of cancer. Vitamin A is necessary for differentiation of specialized epithelial surface, such as conjunctiva covering the eye. In vitamin A deficiency, the thin squamous lining of conjunctiva undergoes metaplasis into stratified keratinizing squamous epithelium. This change is known as keratomalacia. Connective tissues can also undergo metaplasis. A classic example is myositis ossificans, in which connective tissues within muscle changes to bone during healing after the trauma. Next is dysplasia. Disordered cellular growth, most often referred to proliferation of precancerous cells, often arise from long-standing pathological hyperplasia, for example, endometrial hyperplasia or metaplasia. Example of metaplasia is Barrett esophagus. Dysplasia is reversible, in theory, with elevation of inciting stress. For example, cervical intraepithelial neoplasia or CIN represent dysplasia and is a precursor of cervical cancer. If the stress persists, dysplasia progresses to the carcinoma, which is irreversible. Aplasia and hypoplasia. Aplasia is a failure of cell production during embryogenesis, for example, unilateral renal agenesis. Hypoplasia is a decrease in cell production during embryogenesis resulting in relatively small organs, for example, streak ovary in Turner syndrome. Cellular injury. In this section, we're going to look at basic principle, hypoxia, reversible and irreversible cellular injury. Starting with basic principles. Cellular injury occurs when stress exceeds the cell's ability to adapt. The likelihood of injury depends on the type of stress, its severity, and the type of cell affected. Common causes of cellular injury include inflammation, nutritional deficiency or excess, hypoxia, trauma, or genetic mutation. Neurons are highly susceptible to ischemic injury, whereas skeletal muscles is relatively more resistant. Slowly developing ischemia, for example, renal artery atherosclerosis, result in atrophy, whereas acute ischemia, for example, renal artery embolus, result in the injury. Hypoxia. Low oxygen delivery to tissue is known as hypoxia, which is important cause of cellular injury. Cause of hypoxia include ischemia, hypoxemia, and decreased oxygen carrying capacity of blood. Ischemia is decreased blood flow through an organ, which can arise with decreased atrial perfusion, decreased venous drainage, shock, generalized hypotension resulting in poor tissue perfusion. Low oxygen delivery to tissue is important in causing cellular injury. Point number one, oxygen is final electron acceptor in electron transport chain of oxidative phosphorylation. Decreased oxygen will impair the oxidative phosphorylation, resulting in decrease in ATP production. Lack of ATP then leads to the cellular injury. Hypoxemia is low partial pressure of oxygen in blood, which arise with high altitude. Decreased barometric pressure result in decreased partial pressure of oxygen. Hypoventilation increased the partial pressure of carbon dioxide, which will result in decrease in partial pressure of oxygen again. Diffusion defect, partial pressure of oxygen not able to push as much oxygen into the blood due to the thicker diffusion barrier. Mismatch, blood bypass oxygenated lung, or oxygenated air cannot reach the blood. Decreased oxygen carrying capacity arise with hemoglobin loss or dysfunction. Examples include anemia, where partial pressure of oxygen is normal but RBC's mass decreases. Carbon monoxide poisoning is another example of this scenario. Number 1. Carbon dioxide binds to hemoglobin more avidly than oxygen. Partial pressure of oxygen is normal and the saturation will decrease. Exposures include smoke from fires and exhaust from the cars or gas heaters. Classic finding is cherry red appearance of the skin. Early signs of exposures include headache. Significant exposure lead to coma or death. Next is methemoglobinemia. Iron in heme is oxidized to FeH, which cannot bind to oxygen, where partial pressure of oxygen is normal and saturation will decrease. Since seen with oxidant stress, for example, sulfur or nitrate drugs or in newborn. Classic finding is cyanosis with chocolate colored blood. Treatment is intravenous methylene blue, which help reduce Fe3 plus ions back to Fe2 state. Reversible and irreversible cellular injury. Hypoxia impairs oxidative phosphorylation, resulting in decreased ATP. Low ATP will disrupts the key cellular functioning, which includes sodium potassium pump, resulting in sodium and water build up in the cell. Calcium ion pumps, resulting in calcium ion built up in cytosol or the cell. Aerobic glycolysis, resulting in switch to anaerobic glycolysis. Lactic acid built up result in low pH, which denatures the protein and precipitate into the DNA. The initial phase of injury is reversible. The hallmark of reversible injury is cellular swelling. Cytosol swelling result in loss of microvilli and membrane bleeding. Swelling of rough endoplasmic reticulum result in dissociation of ribosomes and decrease the protein synthesis. Eventually, the damage becomes irreversible, and the hallmark of irreversible injury is membrane damage, which will then the end result of this will be irreversible injury will lead to the cell death. Plasma membrane damage will result in cytosolic enzyme leaking into the serum, for example, cardiac troponin, additional calcium entering the cell. Number 2, mitochondrial membrane damage result in loss of electron transport chain, linear mitochondrial membrane, cytochrome C leaking into the cytosol, which will then activate the apoptosis. Lysosome membrane damage result in hydrolytic enzyme leaking into the cytosol, which in turns are activated by high intracellular calcium. Last is cell death. Basic principle, then we're going to look at necrosis, gross pattern of necrosis, and apoptosis. Basic principle and necrosis. The morphological hallmark of cell death is loss of nucleus, which occurs via nuclear condensation, which is also known as pycnosis, fragmentation, karyokerosis, and dissolution, karyolysis. The two mechanisms of cell death are necrosis and apoptosis. Number one is necrosis. Death of large group of cell followed by acute inflammation due to some underlying pathological process. Nerve physiologic divides into the several types based on the gross features. Let's look at the gross patterns of necrosis. Coagulative necrosis and then liquefacitive necrosis. Necrotic tissue that remains firm, cell shape and organ structure are preserved by coagulation of proteins, but the nucleus disappear. Characteristics of ischemic infarctions of any organ except the brain. Area of infarcted tissue is often wedge-shaped and pale. Red infarction arises if blood re-enter a loosely organized tissue, for example pulmonary or testicular infarctions. Liquefactive necrosis, necrotic tissue that become liquefied, enzymatic lysis of cell and protein result in liquefaction. Characteristics of this include brain infarction, proteolytic enzymes from microglial cells liquefy the brain, abscess, proteolytic enzyme from the neutrophils liquefy tissue, and pancreatitis, proteolytic enzymes from pancreas will liquefy parenchyma. Next is gangrenous necrosis and then caseous necrosis. Gangrenous necrosis. Coagulative necrosis that resembles the mummified tissue, dry gangrene, characteristics of ischemia of lower limb and GI tract. If superimposed infection of dead tissue occur, then liquefaction necrosis ensures the wet gangrene. Caseous necrosis, soft and friable necrotic tissue with cottage cheese-like appearance, combination of coagulative and liquefactive necrosis. Characteristics of granulomatous inflammation due to the tuberculosis or fungal infection. Next is fat necrosis and fibrinoid necrosis. Starting with fat necrosis, necrotic adipose tissue with chalky white appearance due to the deposition of calcium. Characteristics of trauma to fat will affect, for example, breast and pancreatitis, mediated damage to peripancreatic fat. Fatty acid released by trauma, for example, to breast or lipase to pancreatitis, joined with calcium via a process called sponification. Sponification is an example of dystrophic calcification in which calcium deposits on the dead tissue. In dystrophic calcification, the necrotic tissue acts as nidus for calcification in the setting of normal serum calcium and phosphate. Metastatic calcification as opposed to dystrophic calcifications occur when high serum calcium or phosphate levels lead to calcium deposition in normal tissue. For example, hyperparathyroidism leading to the nephrocalcinosis. Fibrinoid necrosis. Necrotic damage to the blood vessels wall, leaking of protein, including fibrin, into vessels wall result in bright pink staining of the wall microscopically. Characteristics of malignant hypertension and vasculitis. Next is apoptosis. Energy ATP dependent genetically programmed cell death involves single cell or small group of cells. Examples include endometrial shedding during menstrual cycle, removal of cell during embryogenesis, series to T cells mediating killing of virally infected cell. Morphology. Dying cells shrink, leading cytoplasm to become more eosinophilic. Nucleus condenses and fragment in an organized manner. Apoptic bodies fall from the cell and are removed by macrophages. Apoptosis is not followed by inflammation. Apoptosis is mediated by caspases that activate proteases and endonucleases. Proteases will break down cytoskeleton and endonucleases will break down DNA. Caspases are activated by multiple pathways. Fat necrosis of peripancreatic adipose tissue. Intrinsic mitochondrial pathway is number one. Cellular injury, DNA damage, or decreased hormonal stimulation will lead to an inactivation of BCL2. Lack of BCL2 allows cytochrome C to leak from inner mitochondrial matrix into the cytoplasm and activate caspases. Next is extrinsic receptor ligand pathway. FAS ligand binds FAS death receptor to CD95 on the target cell, activating caspases, for example, negative selection of thymocytes in thymus. Tumor necrosis factor TNF binds TNF receptor on the target cell, activating caspases. Cytotoxic CDs T cell mediated pathway. Number one, perforin secreted by CDs T cell create pores in membrane of the target cells. Number two is granzymes from CDs T cells enter pores and activate caspases. CD T cell killing of virally infected cell is an example. This is all for today. If you like my video, don't forget to subscribe for more.